and foremost thing which is important in the aneurysmal surgery is the subarachnoid dissection. So knowledge on the understanding of the cisterns is very, very important. So there are various cisterns in the skull base, and each cistern has certain vessels related to it. So this is the callosal cistern, the lamina terminalis cistern, so in which the AC, anterior cerebral artery, and anterior communicating arteries are related. This is the chiasmatic cistern. The optic chiasma and anterior communicating artery is related to here. The carotid cisterns, and in which the carotid artery lies. This is the crural cistern. This is a crural cistern where the posterior cerebral artery P1 PCA lies. This is the ambient cistern where the P2 PCA and the pica lies in the ambient cistern. This is the interpeduncular cistern where the bifurcation of the basilar artery into P1 PCA happens. So the interpeduncular cistern, the basilar bifurcation lies in the interpeduncular cistern. This is the lateral cerebellomedullary cistern where the vertebral artery is related to it, the lateral cerebellomedullary cistern. And then the pontine cistern. So the various cisterns are related to some particular vessels. So when you are approaching each and every aneurysm, so understanding the anatomy of the cisterns is very important. So the P1 PCA lies in which cistern? P1 PCA lies in which cistern? Okay. Okay, I'll repeat again. So this is the callosal cistern. So here the anterior, this is a sagittal view. The anterior cerebral artery is related to the callosal cistern. This is the lamina terminalis cistern. This is the interpeduncular cistern. This is the lateral cerebellomedullary cistern and the quadrigeminal cistern. So the various vessels are related to it. So here the pericallosal artery is related, the anterior communicating artery is related, and in the interpeduncular cistern, the basilar bifurcation is related, and the pica is related in the lateral cerebellomedullary cistern. So this is how the cisterns appear. Though there will be various trabeculations inside the cisterns. So these are avascular trabeculations, the arachnoid trabeculations. So dissections along these trabeculations helps us to mobilize the vasculature, mobilize the arteries. So these are the pathways of subarachnoid dissection. So with the main workhorse for the neurosurgeon is the pterional craniotomy. So with the pterional craniotomy and adequate Sylvian dissection, we can get this exposure. So it begins with the splitting of the Sylvian fissure and opening the carotid cistern. So this is the carotid cistern. So what the structures you are seeing is this is the bifurcation of the internal carotid artery into medial A1 ACA and lateral M1 MCA. And this is the optic nerve, and then joining with the opposite side, forming the optic chiasma. And these are the lenticulostriate arteries arising from the superior border of the A1 ACA and M1 MCA. Okay, so this is the optic nerve. This is the internal carotid artery bifurcation to medial A1 ACA and lateral M1 MCA. And these are the medial and lateral. This is the medial lenticulostriate arteries arising from the A1 ACA. These are the lateral lenticulostriate arteries arising from the M1 MCA. This is the posterior. This is the posterior communicating artery joining with the P1 PCA, and this is the posterior. This is the superior cerebellar artery. And this is the third nerve which is running between the posterior cerebral P1 PCA and the superior cerebellar artery. So this is the posterior communicating artery. So any aneurysms of the posterior communicating artery will be compressing the third nerve, resulting in the third nerve palsy. So you will have an anisocoria. So in posterior communicating artery aneurysm, the third nerve involvement will be there. So the various cisterns associated with it. So the Sylvian cistern will be approached for doing the Sylvian split. And then the carotid cistern has to be opened to expose the ICA bifurcation. And then the lamina terminalis cistern, which is here, once you retract the frontal lobe somewhat here, we will reach the lamina terminalis cistern to access, to let out the CSF and for the approaches to the anterior communicating artery. This is very, very important. And then once these anatomy is dissected, then you can get through here and approach the crural cisterns and the interpeduncular cisterns. So this is the zooming of this part. So this is the ICA bifurcation. So for most of the aneurysmal surgeries, we need to start from here. So there are certain safe areas for dissecting the vasculature. So the medial border of the ICA has no branches. So you can have a good dissection along the medial border of the ICA, or in other words, the optico-carotid system. So this is the optic nerve, this is the ICA. So the dissection along the optico-carotid system is a safer thing. There will be no branches at this point. And then the inferior border of the A1 ACA also has no branches. So you can go along the medial border of the ICA and then the inferior border of the A1 ACA. So these are some safe areas. And then again, the inferior border of the M1 MCA. Whereas the superior border of the A1 ACA and the M1 MCA has the medial and lateral lenticulostriate arteries respectively. So it is unsafe to do dissection along the superior border, which can result in injury to these vessels, which can result in gangliocapsular infarcts. So dissection along the superior border has to be very meticulous, or should be avoided. So these are easy areas where you can comfortably dissect along the optico-carotid cisterns. So P1 PCA lies in the interpeduncular cistern. So then the principal surgical steps involved will be, the first and foremost is getting an adequate brain retraction and relaxation. So every time we should not try to put the lela retractor and retract the brain. So that is what is called as the dynamic retraction and static retraction. So static retraction is what putting a lela retractor and retracting the brain. Dynamic retraction is trying to retract the brain when with the suction or with the dissecting forceps when you are handling it. So that is called as the dynamic retraction. So try to have a dynamic retraction to avoid a retraction brain injuries. So also to achieve adequate brain relaxation, we can most of the times patients may present with hydrocephalus. When the patient has aneurysmal rupture, it can result in intraventricular hemorrhage, and that can result in hydrocephalus. So try to put an EVD on the contralateral side and let out the CSF so that the brain starts relaxing. So ventriculostomy on the opposite side of the craniotomy is very important before starting the procedure to achieve good relaxation. And the other method of letting out the CSF is placing a lumbar drain and letting out the CSF. And that is one method of bringing the brain relaxation. And the release of CSF can also be brought out through the understanding of the cistern anatomy. So do a meticulous dissection along the cisterns so that the CSF is again let out. So by achieving CSF drainage, adequate brain relaxation can be achieved either by placing an EVD, by doing an ventriculostomy, or by draining the lumbar by using the lumbar drain, or by doing a meticulous cisternal dissection. So from the pterional approach, the sylvian, carotid, lamina terminalis, and the interpeduncular cisterns can be reached. In the far lateral approach, the posterior and lateral cerebellomedullary cisterns can be dissected to have adequate CSF release. In other cases, in case of interhemispheric approach for the pericallosal arteries, be it proximal or distal, the positioning the patient itself helps in adequate brain mobilization. So I will show you how the patient will be positioned in case of pericallosal artery aneurysms, whether it is proximal, how the patient should be positioned, and if it is a distal, how they should be positioned. And the other pharmacological agents which can be used to decrease the brain pressure is the hypertonic solutions, the metabolic suppressive agents like thiopentol or propofol, and by elevating the patient head, ensuring adequate cerebral venous drainage, by hyperventilating the patient, and by removal of enough bone, by doing an adequate craniectomies. Then the vascular control. So it is very important to have a proximal control. So if you are dissecting, doing a dissection along the MCA bifurcation aneurysm, so it is important you define the ICA bifurcation and dissect the M1, MC, and then get into the bifurcation aneurysms. So getting an adequate control of the proximal control is very, very important. So because once if any mishap happens or any rupture of the aneurysm happens or any bleeding happens, then immediately put a temporary clip along the proximal control. So which will stabilize the bleed, and then you can visualize the aneurysm clearly and then go ahead with the permanent clipping. So the various clips so this is how the view of the aneurysm should be adjusted, whatever the aneurysm could be. So the various types of clippings, the simple clipping, multiple clips, intersecting clips, stacked clips, overlapping clips, fenestrated clips. So there are various types of clips.